This topic is about hematuria. We are going to discuss definition of hematuria, different types of hematuria, causes of hematuria, and how to approach a case of hematuria. Hematuria is defined as presence of blood in urine, which is classified into two types, gross hematuria and microscopic hematuria. Gross hematuria is due to presence of blood which can be seen by the naked eye, in which the urine appear as red or brown. Microscopic hematuria cannot be detected by naked eye but only by microscopy of the centrifuge urine sample. Color of urine in gross hematuria is usually not related to the amount of blood loss. The color can vary from red to brown. As little as 1 milliliter of blood can change the color of the urine. Presence of clot in the urine usually indicate a source of bleeding in the lower urinary tract, but sometimes it occurs from the kidney in case of malignancy. In case of gross hematuria, first we should exclude contamination from other source of bleeding like menstrual blood, postpartum blood, or blood loss from the rectum. At first we should do a centrifugation of urine sample and notice the color of the sediment and the color of the supernatant. The supernatant should be clear, but sometimes it become pigmented or appear with color change in case of presence of dye or presence of hemolyzed red blood cells. Gross hematuria can occur also with some glomerular disease, so it can cause a visible color change of the urine. This is a different degree of color change which is caused by gross hematuria, which can be seen by the naked eye. First sample on the right appear to be clear. Second sample is slightly dark, and the condition can vary from red to deep brown color. Microscopic hematuria is defined as presence of 3 or more red blood cells per high power field, which is a very low cut-off level, which is intended to have a high false positive cases, which is better than missing case with hematuria and serious urinary disease. Examination of urine with urine dipstick can detect up 1 to 2 red blood cells per high power field, which have even more high false positive rate, and result of urine dipstick should always be confirmed by examination of urine sediment by microscopy. False negative cases is very rare in case of testing urine with microscopy or urine dipstick. Some conditions can simulate or missed as hematuria like contamination of urine with menstrual blood. Some drugs like pyridium, phenytoin, rifampin, nitrofurantoin, some pigment like food coloring or beetroots also can cause color change of urine, which sometimes can be misdiagnosed as hematuria. The etiology of hematuria can vary with age. The most common cause of hematuria is infection. This slide can show the commonest cause of hematuria at different age group. If we can see, the intrinsic glomerular disease can occur at any age from young to advanced age. Cancer and benign prostatic hyperplasia usually occur at a more later age. Polycystic kidney disease starts from the age of 20s. Later on, also trauma can occur at any age. Urinary tract infection can occur at any age. Stone usually occur starting from young adulthood later on. Transient unexplained hematuria can occur at any age group, while endometriosis usually occur as a childbearing period, and trauma can occur also at any age. Anatomically, the causes of hematuria can be classified into renal or post-renal according to the source of bleeding. Renal causes of hematuria can vary, include benign renal mass like angiomyolipoma, oncocytoma, and abscess, malignant renal mass, renal cell carcinoma, transitional cell carcinoma, glomerular source of bleeding. The commonest is IgA nephropathy, thin basement membrane disease, and Albert syndrome. Structural disease like polycystic kidney and medullary sponge kidney, pyelonephritis, hydronephrosis, hypercalciuria, and hyperuricemia, malignant hypertension, renal vein thrombosis, and renal artery embolism, arteriovenous malformation, papillary necrosis, which can occur with sickle cell disease or analgesic nephropathy. Other sources of hematuria apart from the kidney can be from the bladder, urinary bladder, which can include malignancy like transitional cell carcinoma, squamous cell carcinoma, radiation, cystitis, bladder stone. Source may be from the prostate and urethra like benign prostatic hyperplasia, prostatic cancer, and prostatic procedure like biopsy, transurethral dissection, also traumatic catheterization, urethritis, and urethral diverticulum. Some causes of hematuria can arise from the kidney or lower urinary tract like infection, malignancy, urolithiasis, tuberculosis, schistosomiasis, trauma, and recent instrumentation or exercise-induced hematuria. Sometimes a bleeding tendency as a generalized disorder of coagulation in the body can be a cause of hematuria. History often gives a clue to the cause of hematuria. For example, a history of exercise or vigorous exercise and an absence of other causes of hematuria can denote exercise-related hematuria. In a patient with recent upper respiratory infection, hematuria can be related to infection-related glomerulonephritis like IgA nephropathy, post-infection glomerulonephritis, and in some cases antiglomerular basement membrane disease. In a patient or a female with cyclic hematuria related to menstruation can be a contamination of menstrual blood and sometimes endometriosis of the urinary tract. In a patient with a family history of hematuria can be related to some familial disease like polycystic kidney disease and thin basement membrane disease. Patient with unilateral flank pain and hematuria can be related to unilateral obstruction of the ureter with stones, but sometimes it can occur in a patient with IgA nephropathy and patient with renal tumor. Patients with the symptoms of prostatic obstruction usually denote the prostate as a source of bleeding. In a patient with generalized bleeding disorder can indicate that urinary bleeding is a part of generalized disorder. A patient with sickle cell trait and bleeding can occur with papillary necrosis, which can occur in those patients. Some drugs can cause renal damage, some drugs can cause color change of the urine, and the history of drug is very important in exploring a case of hematuria. How to evaluate a case of hematuria? First step, we have to confirm hematuria. We have to confirm this color change of the urine is not due to drugs, is not due to dye, and is not due to myoglobin, for example. If we are in doubt about contamination of menstrual blood, for example, we have to repeat the test away from menstruation time. We have to search for a clue in the history, and then we will proceed according to suspected cause. For example, in a patient with hematuria and unilateral flank pain, we have to proceed by radiological examination like CT. And if the symptoms are suggestive of infection, we have to do urine culture and give proper antibiotic according to urine culture, and we have to repeat the urine analysis later after finishing treatment. If there is no evidence of infection and there is gross hematuria and the presence of clot, we have to proceed using CT urography. Gross hematuria without clot may be due to achy eye, glomerular source of bleeding, or urolithiasis. Microscopic hematuria may be glomerular, may be UTI or tumor, and then we can proceed using imaging and cystoscopy. An important step in evaluation of a case of hematuria is to identify the source of bleeding, whether glomerular or non-glomerular. This is an important step so as to direct the investigation properly. The presence of dysmorphic red blood cells, proteinuria, cellular casts, red cell casts, or renal insufficiency are indicative of glomerular source of bleeding. Dysmorphic red blood cells are disfigured red blood cells which are distorted due to mechanical passing through the glomerular capillaries or osmotic effect through passing through the renal tubules. The start of hematuria usually associated with proteinuria of about 500 mg per day. However, if hematuria started in a patient with already proteinuria in the previous time, in this case we have to investigate the urinary tract because maybe the source is non-glomerular. The presence of red cell cast is usually associated with glomerulonephritis or vasculitis. Acanthocyte is a special form of disfigured red blood cells, and if its number exceeds 5% of excreted red blood cells is indicative of glomerular source of hematuria. But the problem of testing acanthocyte is that it needs a phase contrast microscopy which is not available. This slide shows different form of acanthocyte, which is a dysmorphic red blood cells which have a ring shape and have some vesicle or protrusion. This is also a acanthocyte which appear have ring shape and have vesicle or protrusion due to disfigurement, both mechanical and osmotic. Another form of dysmorphic red blood cells, which are indicatives of glomerular source of bleeding. What is the role of renal biopsy in diagnosis of hematuria? Renal biopsy is usually done in a case of glomerular source of hematuria, as indicated by presence of red blood cell cast, dysmorphic red blood cells, or proteinuria. Usually, renal biopsy is not done in a case of isolated hematuria. If there is any evidence for deterioration of renal function like severe hypertension, impairment of renal function, or deterioration in the degree of proteinuria, renal biopsy is usually done. The finding of renal biopsy in a case of hematuria, the most common finding is IgA nephropathy, followed by thin basement membrane disease, sometimes mild nonspecific glomerular abnormality, and hereditary nephritis. What are the risk factors for malignancy? If these risk factors are present, we have to search for malignancy as a cause of hematuria. These risk factors include male, gender, age above 35 years, past or current smoking history, occupational exposure to chemicals, history of gross hematuria, history of irritative voiding symptoms, history of chronic urinary tract infection, history of pelvic irradiation, history of exposure to cyclophosphamide, history of chronic indwelling foreign body, history of analgesic. If history, urine analysis, imaging study, or cystoscopy fail to show the cause of hematuria, it is called unexplained hematuria. This may be transient or persistent. The most likely causes of persistent isolated hematuria, isolated means there is no associated urinary finding or renal function disorder, is the presence of mild glomerulopathy, especially IgA nephropathy and Albert syndrome, predisposition to stone disease, nutcracker syndrome, in which the left renal veins is compressed between the aorta and superior mesenteric artery, loin pain hematuria syndrome, which is a rare condition in which there is attack of loin pain associated with hematuria and dysmorphic red blood cells. Usually this condition is associated with normal renal function. Regular follow-up for a patient with unexplained persistent hematuria is recommended, and annual urine analysis is recommended for those patients. Repeating initial urological workup every 3 years, trying to find a cause. And ultrasound and cystoscopy should be repeated at 1 year interval. There is no recommendation as regards screening for hematuria in any group of patients. And as regards the treatment of hematuria is the treatment of the cause, because hematuria itself is not serious for the patient, but it indicates the underlying disease. Unless hematuria is severe and the source is lower urinary tract, in which severe bleeding can cause hemodynamic instability or can cause anemia on the long term. Sometimes blood clot can cause obstruction of the urinary tract, like clots which can obstruct the ureter. In these conditions, the hematuria itself can harm the patient. Thank you.